Welcome to Snoring and Sleep Apnea Basics, Essentials You Need to Know to Implement Treatment into Your Practice. I need to say this webinar is informational and should not be relied upon for medical decisions. We will be generalizing for this webinar, and some ideas, concepts, and guidelines may not be in accordance with your district's regulations. This is an international webinar, and you should consult with your governing board on the exact laws, guidelines, regulations, and standard of care issues that apply to you and your practice. I want to get started and say thank you to Keller Labs for sponsoring this and putting this on for us. If you have not dealt with Keller Labs, they are a full-service lab. They specialize in everything, but they also do the NTI. And if you haven't worked with the NTI, it is absolutely something you should consider in your toolbox for working with these types of patients. And of course, they have free shipping when you bundle 2 or more cases in a box. I want to introduce myself. My name's Larry Twersky. I am the CEO and founder of 1-800-SNORING and 1-800-SLEEP-MED. I got involved in understanding snoring and sleep apnea when my father, who was undiagnosed with it, would used to come home every day after a hard day of work, and he was so tired that he really just wanted to go sit on the couch and snore. And I, who was a kid at the time, really wanted to spend time with my dad, and really this disease robbed him from me from my childhood. During this time, I've also on the board of and director of Oral Health America for the board of directors. And Oral Health America specializes in the medical dental dialogue. Oral Health America has a new gala coming up. I guess it's coming up in the Chicago midwinter. And their goal is to seal 2 million kids' teeth and do Smile Across America. So you should be, if you want to look at oralhealthamerica.org, they're a great organization to look at. I'm also a member of the Periodontal Coalition and past president, officer, and shareholder of 1-800-DENTIST, where we saw millions of transactions of people looking and asking for dental information and questions. I want to introduce my co-presenter, Dr. William Hart, MD. He's also a member of the Fellow of College of Chest and a Fellow of the American Academy of Sleep Medicine. He's also on the clinical faculty of Stanford University, been doing this 16 years in pulmonology and critical care, and he's also the inventor of the OPAP, which I am going to talk about in a little bit. Before I say that, Dr. Hart's views and opinions are expressed are his and his alone and do not reflect the positions of any institution or company he works for or belongs with. Dr. Hart, welcome.
Good afternoon, Larry, and good afternoon to our audience out there.
Let's start with a little bit, Doctor, about how big this industry is and what's going on with it. Can you talk a little bit about the millions and demands on this industry that we're about to go over?
Well, it's very common, and we're learning that we probably haven't even scratched the surface in terms of the number of cases that are out there. There's been some perspective placed in terms of the prevalence in the population in general. It's currently the level of prevalence is similar to the amount of cases we see with asthma, and it's as common as diabetes in the general population. Different subgroups may have an increased risk. Those subgroups can be the elderly. It's even been discovered that perhaps in diabetics and in, interestingly, commercial truck drivers, there seems to be quite an increased tendency for having obstructive sleep apnea. If you look at this slide, there's at least an estimate here. This slide is at least a couple years old, that there's probably about 46 million people that are affected and undiagnosed at this portion of time. And so that sort of gives you a perspective of the number of cases that we haven't even begun to touch at this point.
Thank you. And I got to tell you, this is, you know, Part of the reason, a lot of the people on are going to be dentists and dental offices, and I thought it was really important that we brought an MD in to really talk about this, because this is really about the medical-dental dialogue, and that how are we going to work with as a group to really combat this problem. And I thought this was an interesting slide that I saw, which is if you were at the Indy 500 this past year, in the crowds and in the stands, 18,000 undiagnosed obstructive sleep apnea attendees were there. That's just a huge number when you think about what we've got happening in this industry. Let me take this one, and Doctor, why don't you talk about the rule of 3?
Well, I think you put this slide up here saying that we could go 3 weeks without food, 3 days without water, but generally we can't go for more than 3 minutes without oxygen or without good airflow. And that puts it into perspective. And I would say that the other corollary to this slide is that the 3 minutes without oxygen can occur when you're not aware that it's happening, which is during the sleep period. And that's why it's an insidious and, as we'll discuss further, a potentially life-threatening condition.
Yeah, and when you've done this, I know you get a lot of patients and you do sleep tests. What's the most you've seen people not breathe for and still live?
Well, I've never actually seen someone hold their breath during sleep for more than 2 minutes. They'll generally will wake themselves up at that point. I'm sure someone can hold their breath up to 3 minutes, but I've never seen it in sleep testing. And I think that when we get to that point of 2 to 3 minutes without breathing, our technicians will intervene. But also, a person like that would be likely to have a cardiovascular event, a stroke, or potentially a heart attack at that point with that much oxygen deprivation.
Well, I know today's topic is about snoring and sleep apnea basics and the essentials you need to know to implement your practice. Let's talk a little bit about some of the terminology we need to know, doctors, so that we can be better briefed and have a better understanding of what it is that we're talking about.
So apnea is a Latin term meaning without breath, and sleep apnea means that it's primarily occurring when you're asleep. So there are occasions where people will describe, well, I notice that I'm not breathing while I'm awake. So that can partially occur when you're awake, but you will certainly be able to remedy it by taking a deep breath. During sleep, however, because you're unconscious, you can't really resolve that without waking up to some degree. And hypopnea is another type of term which you might hear very commonly. It relates to a different degree of the severity of stopping breathing, and we'll describe this in a little more detail in a much more representative slide coming up.
Yeah, and in the medical industry, when the sleep medicine talks about apnea, they have a certain criteria for it. What is that? Is it 10 seconds?
Yes. Well, this is measured based on an airflow signal, typically the nasal pressure airflow signal, and the current definition is holding or lack of airflow for at least 10 seconds at a minimum. So 9 seconds, we would say that it's not an apnea. 10 seconds is our cutoff. And in children, it's a little bit different. But for adults, 10 seconds is the definition for an apnea.
All right, so 10 seconds for an apnea, and got it. And so let's talk about snoring. Is snoring, what is it?
Snoring is basically a closure of the throat, and because we have to draw air down into our lungs, the portion of the throat behind the tongue muscle can get quite floppy, and so as we try to draw air in, it also at the same time can draw in the soft tissues. And it's somewhat similar. I liken it to basically sucking on a wet paper straw. The harder you draw on it, the more collapsible that area can occur. And when it passes through that constriction, it makes a vibration and also a certain amount of air turbulence, and that's what's creating the snoring sound. I think the biggest thing that we would want to pass on here is that snoring is not considered to be normal. Culturally, I think we think it is normal because we watch TV and someone's snoring, so we know they're asleep. But snoring really means that the airway is compromised, and that's why someone is making that kind of noise.
All right, but not all snorers have sleep apnea. Is that also something we should take away from right here?
Well, that's something that I think the next few slides will discuss, is that we're dealing with the same area of the throat, and that area of the throat can be quite floppy in different degrees. So snoring is part of the, is a symptom or a sign of a constriction of the airway. And the answer to what you had just asked me was that, yes, we do have some occasions of patients only snoring, and they don't quite go all the way to having a full apnea, and we classify those persons as having primary snoring. And then the progression of that closure of the airway would then be ending up in a full apnea.
All right, well, I found this an interesting slide. Did you know that, and I know you know, Doctor, but we'll just mention it to the participants, that snoring can be as loud as a jackhammer, a jet engine, a crying baby, a motorcycle, and that a loud person snoring is sometimes over the limit required for hearing protection by OSHA. But let's get back to some medical topics, and it's important that I mention right now to all the participants, if you have a question, there's going to be a question and answer period towards the end, and I have a question box that you can ask the question to, and I'll respond based on that. So if you can just type it in there, we can do it that way. Or I have a team here listening for emails, and you can email us at info@1-800-snoring.com and ask your question if that's easier, and we can go through. But Doctor, let's continue. We have upper airway resistance syndrome. Let's understand a little bit more about this.
So this is like the next degree of closure, perhaps. That's the way to think about it. So on one end of the spectrum, you have snoring, which means a slight constriction of the airway, and then a little bit more of closure of the airway is enough to wake the brain up from sleep. And these repetitive closures of the throat lead to frequent awakenings at a subconscious level during sleep, and this interruption of sleep therefore then leads to daytime fatigue and arousals. So it's part of the progression, it seems, potentially, of this part of the airway that is closing. The reason why it's designated as a separate entity is that the blood oxygen levels can be in the normal range, whereas with sleep apnea, we may see more derangement of oxygen levels. So so you can take from this that oxygen levels are preserved, but it's enough of a change in breathing that we will arouse ourselves to respond to this potential life-threatening threat to us.
Okay, so first there was snoring, then there's upper airway resistance syndrome, then we have obstructive sleep apnea.
So obstructive sleep apnea is the full airway closure, so to speak, the tube or the area behind the tongue, and can close down fully, and there will be a lack of airflow, which is an apnea, for at least 10 seconds. And this primarily occurs, it seems, because of the compliance or the floppiness of the back of the throat.
Okay, and then I think I missed something here. So there's a hypopnea, and so a hypopnea is a 50% reduction of the airflow, and an apnea is a full closure of the airways, right?
Yeah, I think we're going to need the next slide here, Larry, to help fully describe this in a more of a, I think, a representative way. So if the 0% part of this cartoon here shows, means that there is a 0% closure. and 100% would indicate 100% closure of a tube.
So is that red that we're looking at like the tongue? Or
that would represent perhaps the tongue and the soft tissues of the throat, and the blue portion would represent the size of the airway opening. So snoring is a partial closure. Upper airway resistance might be about the same or a little bit more. And a hypopnea would perhaps be a partial closure, as you see here. And then an apnea would be a full closure where there would be no airflow through this opening in the tube. It would be as if we were standing on the top of the tongue, looking down toward the stomach, and perhaps this is what we would see if we were a little camera in that area during sleep.
All right, so then what we would want really the takeaway here to be is the difference between sleep apnea and snoring is really the sound of the soft tissue vibrating. It's narrowing of the airway, but it's really not closing. So we can really consider snoring as the start of the airway closing. Hypopnea is, and how do you say it? Is it ARERAs, or how do you say that? Is there a medical thing? How do you guys say that?
Yeah, we're getting into a complex area in terms of the experts have agreed on several definitions of this partial airway closure. One is called the upper airway resistance syndrome, and another terminology used for the same concept is called RERAs, or respiratory effort-related arousals. So they're probably very similar. I don't think our audience needs to get into that really tight definition.
So we have a start of the closure of the airways, somewhere in the middle of the closure, and a full closure is really an apnea. Correct?
Mm-hmm.
So okay, great. Let's go to that. And so all that kind of makes up sleep disorder breathing?
Yeah, sleep disorder breathing is a way that we try to encompass all the different possibilities of how breathing can be deranged during sleep. For example, if any of you know about what we call COPD, or chronic obstructive pulmonary disease, that's a catch-all phrase for asthma, bronchitis, bronchiectasis, and emphysema. So all those different conditions fall under that category name of COPD. So similarly here, the various categories of sleep breathing problems are classified under a tag or a moniker of sleep disordered breathing. So it's not a whole different condition. It's sort of our global way of describing all the variations that can occur with breathing during sleep. So hopefully that's helpful when you come across it in your reading.
Okay. And so if we look at the causes of it, let's talk a little bit about what the cause might be.
So the commonest sleep breathing disorder that we have right now is obstructive sleep apnea, and it's typically related to a floppy segment of the so-called tube that leads from the front of the nose all the way back to the back of the throat and then into the windpipe or the trachea. So from the area from the soft palate where it begins up to the epiglottis, you notice that there is no structural support in that area. I mean, there's no bone there. It's all basically soft tissue from the tongue muscle and the epiglottis. And so with the initiation of sleep or deep sleep, there's a lack of motor control of muscles and musculatures, and so this soft tissue area is a collapsible tube, and when we apply a vacuum to it, as we do when we breathe, it can actually draw it all together and pinch off the airway, and therefore air will enter the nose but not get past the tongue area. Even if the mouth drops open and air enters through the mouth area, there's still closure behind the retroglossal area, and therefore it still is a closed airway. When this happens, it's a life-threatening event because, as I said, we need oxygen with at least 2 or 3 minutes. And if we don't get it, then we will wake ourselves up because it's a survival issue. And we could talk about
people will hopefully wake themselves up. Of course, we know that there's been some tragedies of this causing more problems on that one.
Yeah, and
so
I would say that that's related to other factors, as if either someone using alcohol and not recognizing they have this condition, or medications, and that might be contributory to basically dying in your sleep from this condition. I don't want the audience to think that it just occurs out of the blue.
Yeah, no, I apologize. I was not trying to. I was trying to just make sure that we brought up what some of the consequences are of OSA, and bring up the next slide, which we